All right, we're going to stay on the de novo degenerative flatback theme now with MIS approach by Khoi Tan.
All right, good morning, everybody. Like Chris mentioned, my name is Khoi Tan. I'm a spine surgeon at Duke. Actually finished my fellowship at UCSF a decade ago, and it's great to see so many familiar faces, even from the ORs back then. Hey, Hunter. And actually, I've always wanted to be a part of this course, so I'm so grateful to Chris and Vedat and Alekos and Aaron for the invitation. I've been asked to speak about de novo degenerative flatback and which patients are most suitable for MIS approaches. These are my disclosures. I think my most important disclosure are my cases are a lot easier than Manisha's, so take that into account as you listen to my conclusions here. So when we think about which patients are most suitable for MIS approaches, I think it's really important to first ask what is the definition of MIS. And it's really been interesting over the course of the past decade to see how that definition has evolved, right? So when I was first in practice, if a patient got lateral surgery followed by open posterior surgery with osteotomies, that was considered hybrid MIS. And we evolved away from considering those cases to be MIS, since you're opening up the whole back and cutting out bone and all that stuff. And then the definition changed to be MIS lateral with MIS TLIF and MIS percutaneous screws. I think specifically with MIS TLIF at L5 to S1, not getting great lordosis. And so, again, we saw the definitions change a little bit. Let me ask the people in this room, how many of you would consider L5 to S1 ALIF to be MIS? All right, keep your hands up. How many of you would consider L4 to S1 ALIF to be MIS? Still some hands up. L3 to S1? Okay. Oh, hey, Shane. Great. So, I think I've been able to be a part of that conversation. When you ask Google, it doesn't really help much. It's very vague. Even with AI, it's, advanced techniques, small incisions. And I think where the literature is at now is that, at least in the MIS deformity space, we consider L5 to S1 ALIF to be MIS. Anything above that, somewhat longer incisions, vascular mobilization, maybe less MIS than just L5 to S1. From the lateral corridor, lateral interbody surgery, including ACR is MIS, MIS TLIF, and then MIS pedicle screw instrumentation. So when we take this into account and we ask the question, which patients with de novo degenerative flatback are most suitable for MIS approaches, I might argue that all of them are, okay? And I would say that if you have a patent disc space, your flatback can be treated with MIS techniques. And again, my cases are a lot easier than the previous speakers. But when I think about my own practice and I think about patients who've come in needing degenerative fusion or even deformity where the Cobb angle is less than 40 degrees and we do not need to go into the proximal thoracic spine, every single one has been treated with minimally invasive approaches over the past several years. This paper that we put out of the MIS ISSG provided a nice framework for thinking about which interbody techniques allow for the greatest restoration of lordosis. I would say, ignore the lines, but this was, 100 patients with, a few hundred different interbodies placed. And essentially what we came to the conclusion was for the most lordosis, and to keep things MIS, the key is to do ALIF at L5 to S1, lateral interbody surgery at 2, 3, 3, 4, 4, 5, and then L1 and L2. Didn't matter too much if it was lateral or TLIF. Those radiographic outcomes were more or less equivalent. And so when we think about these techniques, ALIF, lateral, ACR, MIS TLIF, how much correction can be accomplished with these techniques? This is a paper out of the BNI fairly recently, 2022, comparing hyperlordotic versus lordotic ALIF, L5 to S1 only. A pretty decent series, 204 patients, 93 had hyperlordotic implants, 111 had sort of regular lordotic implants. And when you look at overall lumbar lordosis, hyperlordotic implants did play a role in increasing lordosis by just a few degrees, 4 degrees, whereas with the 8 or 10 degree cages, not much impact on overall lordosis since the rest of the spine compensated back to where the patient wanted to be. Of course, the segmental numbers were improved at L5 to S1 specifically. Anterior column realignment's a technique I'm really passionate about. I try to do it whenever it's feasible. Juan also wrote the first paper on this technique back in 2012. Small series at that point, just 4 patients, but these patients had improvements in their lordosis by 25 degrees with concordant improvements in VAS and ODI. I think the nicest thing about this manuscript is just the beautiful artwork, which shows as you go just a little bit more anterior in the spine, all the other anatomy you have to be cognizant of. Whether that's the genital femoral nerve, the vena cava, the segmental vessels. But with radiographic improvements of 20 or 30 degrees, a lot of comparisons have been drawn between ACR and PSO. This is a paper out of Virginia Mason with J.C. Levesque and Raj Sethi, who's here, comparing just a small series of patients, ACR versus PSO. You can see similar radiographic accomplishments, about improvements of 30 to 35 degrees of lumbar lordosis, but much less blood loss with ACR. And this out of the ISSG, where Chris and Vedat were co-authors. Similar results, essentially equivalent radiographic outcomes, much less blood loss with the ACR. And this multi-center study out of the BNI and out of Scripps provides a nice framework for us to think about how much radiographic correction can be accomplished with a variety of lateral techniques. So whether it's lateral alone, ACR without osteotomy, or ACR with osteotomy, essentially what we're getting is about 3 degrees of segmental correction for lateral. For an ACR without osteotomy, you're generally getting about half the correction of the cage. So if it's a 20-degree implant, maybe 10 degrees of lordosis, 30-degree implant, 15 degrees. And then once you add the osteotomy, you're getting the full correction of the cage, whether that's 20, 25, 30 degrees, whatever you're putting in. In my practice, the indications for ACR is any MIS case where at least 10 degrees of lordosis is needed, any open case where at least 20 degrees of lordosis is needed. And again, I would say that if you have a patent disc space, ACR is an option for you. And we focused a lot today about lower lumbar lordosis. I'll do a shameless plug for this manuscript we published in World Neurosurgery. When I got to Duke in 2019, there were actually 2 pandemics going on. One was COVID. The other was patients getting fused L2 to S1 completely flat. Not at Duke, of course, just by others. But these patients would come in and I would do L1-2 or L2-3 ACRs on these patients. And we found that even though their apex of lordosis is off, getting substantial improvements in their SVA, their PI to LL, and their outcome scores, ODI, PROMIS, and VAS, without the mechanical failures that we've seen historically with upper lumbar PSO. So just some food for thought. So again, when we take into account these mathematics that I've mentioned, with 4 degrees of improved lordosis with ALIF at 5.1, as much as 15 degrees with ACR without an osteotomy, and then a few degrees for the remaining lumbar levels, really about 30 degrees of possible lumbar lordosis restoration can be accomplished through MIS techniques. And this is without considering that some have even gone on to describe things like, multiple ACRs in a given patient. And I think for a standard practice, again, maybe not like Dr. Gupta's, 30 degrees will usually capture, what you need. And I'll go over a couple of case examples to perhaps demonstrate this. So this is a 67-year-old woman who came in with back pain. Her symptoms were worse later in the day. She's unable to complete her ADLs. She had tried all the non-operative therapies. Her medical history was fairly benign, and her surgical history was just notable for a 1-level lumbar lami. Her examination was normal. Here's her EOS films, which demonstrate an SVA of nearly 13, Cobb angle of 36, PI to LL, a mismatch of about 44, and elevated pelvic tilt of 41. MRI in terms of central stenosis was really just notable for, I would say, moderate stenosis at L3 to L4 there. And you can see in terms of her CT scan, she's fused up front at L5 to S1, but the facets aren't fused, and she has otherwise open disc spaces. So I think maybe I'll ask you, Dr. Gupta, if this comes to your practice, how would you treat this? I see. With the rod, like you described, yeah. I think this is a very great solution. For this lumbar degen scoliosis patient that comes to my clinic, they get what I call the MIS special, which is a 5-1 lift, multiple lateral interbody fusions, and then T10 to S2 percutaneous. But I think Dr. Sethi brings up great points. These are longer surgeries, probably more costly surgeries given the multiple implants being put in, without at this point, aside from maybe less blood loss and perhaps better short-term pain control, not great clearly long-term advantages compared to how an open surgeon would do this. So definitely some questions for all the smart young people in the room to answer. But this is the result. So SVA improved by 11 centimeters down to less than 2. Cobb angle, basically straight, about 30 degrees of lordosis correction, and improvement in pelvic tilt as well. And 6 weeks post-op, back pain's gone. Now, I'd say even though we're doing this surgery essentially without stripping a single muscle off the spine, I think because of the multiple entry points through the psoas, these patients do have transient and subtle hip flexor weakness after surgery. So that's also another thing to take into account. And actually her hip flexor strength didn't interfere with her walking, but at least on confrontation was still present at 6 months and not resolved for about a year. And her outcome was sustained 2 years post-operatively. And these are the side-by-side comparisons. This next case isn't a de novo case per se, but I did want to demonstrate maybe the utility of ACR. So this is a 73-year-old woman, again, back and leg pain, more so back pain, mechanical in nature. Of course, tried all the non-operative stuff. Again, a fairly benign past medical history. And she had a previous L4 to S1 ALIF. Her exam also normal. So a little bit of a different deformity here. So you can see she's been fused flat or maybe even kyphotic at L4 to S1, sagittally imbalanced, coronally imbalanced as well. PI to L mismatch of about 37 and slightly elevated pelvic tilt. In terms of her MRI, moderately stenotic there at L3-4, mildly stenotic at L1, L2. And, you can see L4 to S1's fused. Again, maybe flat, probably not kyphotic, but definitely not very lordotic. Extremely collapsed at 2-3 and 3-4. So again, what would you do here? I can tell you, I've shown this case at a variety of places, Phoenix, Tampa, New York. The trainees, they always say L4 PSO. I think because of the great work that's been done over the past several years. Really, the debate is, after the L4 PSO, do you stop at T10 or do you go up to the upper thoracic spine? But again, in my hands, I did this a little differently. So again, with the goal of making sure the lordosis is as low as possible, ACR at 3-4, regular laterals at 1-2 and 2-3, and then percutaneous from the back. This is actually me doing the case with Andrew Chan, who Chris trained, and was probably the best fellow we had come through Duke, now at Columbia. And these are the results. So again, SVA improved to less than 2 centimeters. Coronally, I wish I'd gotten a little bit better, but I think most people would say, within 3 centimeters would be within the realm of normal. Again, nearly 30 degrees of lordosis correction, this time just through 3 interbody, just through 3 disc spaces. And improvement in the pelvic tilt as well. Again, back pain gone fairly quickly, subtle hip flexor weakness through 3 months, but now she's got a good result sustained through 3 years. And these are the side-by-side comparisons. So again, a little bit different way of thinking about things, but I guess my conclusions would be that most, if not all, cases of de novo degenerative flatback can be treated with these MIS techniques. And I think through a combination of hyperlordotic ALIF, ACR, and lateral interbody fusion, at least 30 degrees of lumbar lordosis can be restored through the lumbar spine. Again, in my practice, all degen patients, all deformity patients with a Cobb angle less than 40, and who don't need to go up to the upper thoracic spine have been treated MIS. I would say I'm biased, but with predominantly good result. And the muscle-sparing nature of these techniques may be beneficial to patients in both the short and the long term. So thank everyone who came to the CNS last month, and invite you to save the date for next year.
questions for Khoi? Yeah, Manish.
But I know that when you go through the psoas, you get the weakness. But one of the most underreported things in surgery is that when you strip the psoas from the spine, they also get weakness, but it resolves relatively quickly. So, you're not the only one that gets that.
Oh, thanks. I feel better now.
I thought it was interesting. You showed some data. I think if I interpret it correctly, that essentially you were saying that even in, for example, like a lower PI patient that has a flat 4-to-1 who's sagittally imbalanced, even though you might think you shouldn't put the lordosis so high, you do a ACR, and it seemed to be okay. That's a scenario we face really more and more frequently, and I'd be interested maybe in Mike's take and when we talk about it during the discussion portion and the cases, but we see so often now the flat 4-to-1. That's a very common problem where you see 25 degrees of lordosis 4-to-1, neck segment disease, and what do? We looked at that from an osteotomy standpoint in the ISSG, and we were thinking we would see just what the French saw, which is, if you just extend the patient, don't do a lower correction, we're going to see a lot of additional failure. And we didn't see it either, actually. Certainly the parameters were a lot better, but the complication rates were higher in the 3-column osteotomies, for example, at 5 or 4, compared to simply doing a correction higher and extending it. So seems to be an unanswered question to some extent. What do you think, Khoi?
Yeah, I think understanding the things that other speakers have mentioned, like spinal alignment, is so important. I think things for, like, example, the Russley classifications really helped us understand, how the spine's supposed to look. But when we come in and when patients come in and they've had this work done and they're pitched forward and, they're hurting because they're breaking down to the level above and they're pitched forward, a lot of times they just need to be a little bit more upright. And if we're able to do that, even though, their spine's not, pretty per se, but they're able to, stand a little more erect and have, concordant improvements in their pain, I think a lot of times they still are pleased with that result.
Great. Well, I think we'll take up more of that debate in the, thanks, Khoi, in the discussion over the cases.